Welcome to AETCM, the Emergency Medicine channel. As a part of EM Rapid 2024, today I am presenting topic is trauma in elderly. Geriatric trauma is defined as the trauma occurring by an age of 65 or older. The elderly have worse outcomes following trauma because of physiological changes that occur with aging. They are more susceptible to serious injuries from low energy mechanism and less able to compensate from the stress of injury and more likely to suffer complication during the treatment and recovery. The physiological changes of aging complicate recovery from injury and make the assessment of injury more difficult. With age, myocytes are lost and replaced by collagen. An 80-year-old person will have approximately 50% of the cardiac output of a 20-year-old even without significant coronary artery disease. And maximal heart rate and cardiac output decreases with age. Aging myocardium has a decreased chronotrophic response to catecholamines and is dependent on preload. Hypovolemia can easily result in shock. Deterioration of the cardiac conduction system leads to AF and bundle branch blocks. Medication, especially digoxin, beta blockers and calcium channel blockers, impair the tachycardia response to catecholamines, both impairing the body's inability to compensate for hemorrhage and making heart rate an unreliable predictor of hypovolemia. Chest wall complications, respiratory muscle strength and the capacity for oxygen exchange all are decreased with age. The response to hypoxia may decline by 50% and that to hypercarbia by 40%, such that the patient may not appear to be in respiratory distress despite impending respiratory failure. Weakened respiratory muscle and degenerative changes in the chest wall, maximum inspiratory and expiratory force may be decreased by up to 50% compared to a younger patient. Age-related reduction in vital capacity, functional residual capacity and forced expiratory volume can limit older patients' ability to compensate for chest injuries. Renal function declines with age and predisposes patient to dehydration, requiring medication dose adjustment and making them susceptible to acute kidney injuries. And common mechanism of injuries in older people: fall, motor vehicle crashes, pedestrian vs motor vehicle collision, burns and elderly abuse. Falls are the most common cause of fatal and non-fatal injury in people more than 65 years of age. Hip fracture are the most common fracture in elder hospitalized for injury. Age-related changes in postural stability, balance, motor strength, coordination and reaction time that makes the elderly more prone to falling. Falls in which an individual is unable to get help for a prolonged period should prompt investigation for rhabdomyolysis and dehydration with check of the creatine kinase and electrolytes. And common mechanism of injuries that causing fall in elderly associated with syncope or loss of consciousness, transient loss of consciousness is dysrhythmia, seizures, MI, hypoglycemia, pulmonary embolism. Associated with near syncope or positional change, vasodilatation like antihypertensive medication, dehydration, hemorrhage, sepsis, anemia. Second one is motor vehicle crashes. Motor vehicle crashes are the second most common cause of injury in elderly. Pedestrian vs motor vehicle collisions. The elderly are second only to children as victims of pedestrian vs motor vehicle collisions. Burns. Burns are the second leading cause of traumatic death in home in older adults. There is a direct relationship between age and burns mortality as evidenced by the traditionally thought mortality predicting box score. Elder abuse. Maintain a high suspicion for intentional injuries, injuries caused by neglect. Warning signs include poor hygiene, untreated decubitus ulcers, injuries not explained by the reported mechanism, subacute injuries in various stages of healing. Clinical features. In history, treat the injured elders as both trauma and medical patients. Avoid skipping the review of system, past medical history and medication list. Investigating the cause of fall may uncover serious underlying medical causes or prevent further trauma. Going to primary survey, avoid feeling reassured by a normal vital sign. A tachycardia response to pain, hypovolemia, anxiety may be absent in elderly trauma patient because of it is covered by medications like beta blockers may mask the tachycardia and hinder the evaluation. Blood pressures are also misleading in elderly patients. In blunt trauma patients more than 65 years old, there is an association between hypotension and mortality starting with systolic blood pressure less than 110 millimeter mercury and heart rate more than 90 beats per minute. A decrease in blood pressure of 30 millimeter mercury below a known baseline or falling trend is also a marker of instability. Anatomic variations may complicate airway management. This includes the presence of dentures which may occlude the airway and make the laryngoscope more difficult. So before going to maintain the airway, we will remove the dentures. And cervical arthritis, which adds danger to extending the neck, or temporomandibular joint arthritis, we is not able to tilt the head while doing intubation. Secondary survey, patients with no apparent life-threatening injuries can have potentially fatal injuries that can be identified in the second survey. Seemingly stable geriatric trauma patient can deteriorate rapidly and without warning signs. Undertake a medication review early in the patient's evaluation and paying particular attention to medication that affect the heart rate, blood pressure and coagulation. Head injury. Elders are less prone to develop epidural hematomas than the general population because of the denser fibrous bond between the dura mater and the inner table of the skull. A higher incidence of subdural and intraparenchymal hematomas in elderly than in younger patients. As the brain mass decreases with age, there is a greater stretching and tension of the bridging veins that passes from the brain to dural sinus. Therefore, bridging veins are more susceptible to traumatic tears. Diagnosis of intracranial bleeding may be delayed because brain atrophy increases the intracranial free space, allowing blood to accumulate between these spaces. An immediate CT brain plane is recommended for patients who take warfarin or clopidogrel and have a minor head injury mechanism even if asymptomatic. Cervical spine injuries. Odontoid fractures are particularly common in geriatric patients. Pre-existing cervical spine pathology such as osteoarthritis, bulging disc, osteoporosis may predispose elderly patients to spinal cord injuries. With hyperextension injuries, elderly patients may develop a central cord syndrome, which causes motor deficits in the upper extremities more often than lower extremities, variable sensory loss, and bladder dysfunction. CT scan is the preferred initial modality for assessing the geriatric cervical spine because of the higher pre-test probability of injury and difficulties in interpreting a plain radiograph in patients with age-related degeneration. Thoracolumbar spine injuries. Thoracic and lumbar spine fractures account for almost half of all osteoporotic fractures. They are most common at the thoracolumbar junction T12 and L1 and mid-thoracic area T7 to T8. Anterior wedge compression fracture are the most common. CT scan is the first line imaging modality for adult patients. Chest trauma. The elderly are more susceptible to chest injuries from blunt trauma and have a decreased ability to compensate for these injuries. Rib fractures in the elderly often lead to morbidity, pneumonia and death. Leads to contusions. Rates of pneumonia and mortality in patients more than 65 years old are twice that of younger patients. Because of the complication associated with rib fracture in elderly, CT may be necessary to assess the extent of injuries. Abdominal trauma. The FAST examination is an ideal imaging study to detect large volumes of free intraperitoneal fluid. Many solid organ injuries can be managed non-operatively. CT with contrast is a crucial diagnostic test for evaluating the extent of injury and ongoing hemorrhage. The risk of acute kidney injury following injury increases with age, hypovolemia, diuretic and nephrotic medication, diabetes and pre-existing renal disease. The contrast-induced nephropathy risk can be reduced by volume expansion with isotonic crystalloids. The fast examination in ideal image detect large volume of free In orthopedic injuries, pelvic fractures, elderly, especially women, frequently suffer pelvic fractures from low energy falls to the ground from a standing or seated position. Pubic ramus fracture are the most common injuries, and lateral compression is the most common mechanism. CT of the pelvis should be ordered in the stable patient with pelvic tenderness after an injury if plain radiographs are negative. Consider MRI for patients with pelvic pain or pain on weight bearing with negative CT imaging. Hip fracture. Hip fracture is the single most common injury diagnosis that leads to hospitalization in the elderly. Hip fracture are significant cause of mortality, with about 25% of elderly patients dying within a year of injury. The vast majority of hip fracture are caused by fall to the ground. Normal plain radiograph should be followed by more definitive imaging in patients in whom suspicion of hip fracture persists. MRI has a higher sensitivity than CT for detecting hip fractures. Upper extremity injuries. Distal radius fracture, SCOLIs, are most common fractures in women up to age of 75. Such fractures are often caused by a fall onto an outstretched hand and are associated with low bone mineral density and or osteoporosis. Assess median nerve function before and after reduction. Unstable or displaced fractures required close reduction with a hematoma, block or anesthesia. Fracture of the proximal humerus and humeral shaft are also common after falls from standing. Carefully assess for axillary nerve injury by checking sensation at the area of deltoid muscle insertion and deltoid muscle engagement with shoulder abduction. Out of hospital considerations. Rates of pre-hospital under triage are higher in older than younger patients. Risk of injury, death increases after age of 55 years. Systolic blood pressure less than 110 mm mercury might represent shock after age 65 years. Low impact mechanism, example ground level fall, might result in severe injury. These are the triage recommended lower threshold for triage injured elderly patients. Given three key recommendations are these three. The elderly can rapidly develop tissue damage leading to a decubitus ulcers. Consider padded backboards or vacuum splints for prolonged transport. Patients with cervical kyphosis may need firm padding placed behind the head when in spinal immobilization in order to prevent forcing the spine into an abnormal position. Bleeding and head injury. Rapidly reverse anticoagulants in patients taking warfarin or dabigatran with intracranial bleeding on CT scan. Admit the patients with bleeding on head CT to an intensive care unit. The disposition of patients taking warfarin but with a normal initial CT scan is challenging because such patients have a reported rate of delayed intracranial hemorrhage between 1% to 8%. Admission for a repeated head CT at 24 hours will catch most but not all delayed hemorrhages. Discharge after an initial negative head CT is also reasonable in patients with lower INR and caregivers to watch them closely at home. Rib fracture and respiratory failure. Pain control after chest wall trauma is vital to encourage ventilation in order to reduce the collapse and the risk of infection. Continuous pulse oximetry and capnometry are helpful to assess oxygenation and ventilation. Serial ABGs analysis may provide early insight into the respiratory function and reserve. Consider pumped tracheal intubation and use of mechanical ventilation in patients with more severe injuries, respiratory rate more than 40 breaths per minute, or when the partial pressure of arterial oxygen is less than 60 mm mercury, or the pressure of arterial carbon dioxide is more than 50 mm mercury. Shock. Resuscitate with elderly trauma patient with small volume of isotonic crystalloids and watching for a response to avoid under resuscitation or volume overload. Consider early red blood cell transfusion, which may enhance oxygen delivery and minimize the tissue ischemia. Depending on the type of injury and severity of blood loss, consider switching to blood transfusion after 1 to 2 liters of crystalloid resuscitation. Environmental and iatrogenic injury. The decreased lean muscle mass, impaired peripheral circulation associated with aging make the elderly patient more susceptible to pressure sores and hypothermia. Patients with prolonged extraction or transport in cool climate may be hypothermic. Expose the patient as needed for a thorough examination, but keep the patient covered as much as possible to maintain the body temperature. Hypothermia, not explained by environmental factors, may be a sign of sepsis or endocrine abnormalities. Log roll the patients onto a padded surface as soon as possible. Disposition and follow-up. Admit the elderly patients with polytrauma, significant chest wall injuries, abnormal vital signs, or evidence of overt or occult hypoperfusion to the intensive care unit. Even in patients without the need for inpatient treatment or observation, consider whether the patient is immediately ready to return home with a trial of ambulation and discussion of their home situation. In patients whose pre-injury mobility was already pronounced, pain, decreased mobility, and medications may make a return to home dangerous. While opioid analgesia may be necessary, they may also cause delirium, decreased balance, and impair the ambulation. Observation for establishment of safe and effective pain regimen, consultation with physical therapy, and assurance of safe home environment may be advisable to prevent a secondary injury. Outcome. The ultimate goal is to return the elderly trauma patient to the pre-injury state of function. Elderly patients often return to pre-existing health status after trauma. Aggressive resuscitation efforts for geriatric trauma patients are warranted in keeping with their pre-expressed end life care preferences. Thank you.